Welcome, everyone. I'm Jack Rincon, and I'm here with Dr. Pei Ping. We're pleased to continue the Bridge to AI Training, Recruitment, and Mentoring Working Group Lecture Series for 2025 to 2026, part of our novel AI Technology module. Today's lecture is titled Multimodal Deep Learning Models for Thyroid Cancer Risk Stratification. This session highlights an important frontier in biomedical AI, how we can combine multiple forms of clinical and biomedical data to improve diagnostic accuracy and clinical decision support. Multimodal AI approaches are becoming increasingly important as healthcare data grows richer and more interconnected. Dr. Pepe Ping will introduce our esteemed lecturer.
Thank you, Jack. It's our great pleasure to welcome Professor William Speier, who's associate professor at UCLA, where he holds joint appointments in radiological science, bioengineering, and biomedical informatics. Dr. Speier is also the associate director of the famous UCLA Biomedical Artificial Intelligence Research Laboratory. That's a very strong multidisciplinary research program focused on developing advanced AI systems for biomedical and clinical applications. Dr. Speier's work spans machine learning, deep learning, and statistic modeling applied to complex healthcare datasets, including medical imaging datasets, EHRs, wearable sensor datasets, and clinical text. He has built predictive models and decision support tools to gather and use these datasets to improve patient care. Most importantly, Dr. Speier brings a deep interdisciplinary background at the intersection of biomedical engineering, computer science, and clinical informatics. This came from his education with a PhD in biomedical engineering at UCLA, a computer science master degree at Hopkins, and a biomedical engineering bachelor degree at Johns Hopkins as well. Over the course of his career, Dr. Speier has led the innovation on developing AI-driven methods for analyzing biomedical data. He has focused on developing AI tools for complex biomedical data, particularly integrating different approaches using medical imaging data sets to support clinical decision process. His research program integrates diverse data sources ranging from a number of data modalities, as we have discussed and covered, including CT, MRI, and ultrasound, to clinical documentations and sensor wearable monitoring data. In these settings, his work has been supported through multiple NIH awards, including projects focused on stroke detection using deep learning and predictive modeling of hospital readmission using wearable activity data. Beyond these, Dr. Speier has been recognized with his accomplishment in this area as he has extensive service in the AI and machine learning community. For example, he has editorial service in Frontiers in Human Neuroscience, as well as PLOS ONE. Through his leadership, medical informatics curriculum committee was launched 7 years ago, and he has made enormous contribution to build the program and to guide and mentor the graduate students at UCLA. His work really exemplifies the translation of computational innovation into clinically meaningful systems, and we're so fortunate to have him to share his expertise with us today. I'm going to get back to Jack. He'll introduce the learning objectives of the lectures.
Thank you, Dr. Ping. Before we begin, let's briefly review the learning objectives for today's lecture. First, we'll explore the role of type 1 error in thyroid cancer diagnoses and why understanding diagnostic error rates is critical when designing AI systems intended for clinical use. Second, we'll examine different strategies for integrating multimodal biomedical data, comparing approaches used to combine imaging, molecular, and clinical information in machine learning models. Finally, we'll evaluate the effectiveness and clinical utility of biomedical AI systems, focusing on how multimodal models can support improved diagnostic decision making and ultimately contribute to more reliable and personalized healthcare. With that, I'll turn it over to Dr. Speier to begin today's lecture.
All right, and I will share my screen. Can you see my screen okay? Yep.
Yep.
Awesome. Thank you so much for that great introduction. So as Dr. Ping said, I am William Speier. I am an associate professor at UCLA and co-director of the Biomedical AI Research Lab. And as the way our lab works is we are largely AI researchers, computer scientists, data scientists, and we pair with our clinical partners where they bring us the clinical challenges that they see in their everyday practice, and then bring those to us to try and find solutions where we can apply our methodology and hopefully translate that into improved patient care. So the specific project that I'm talking about today is an ongoing project that we've been working on for about 5 or 6 years, which is generally the application of AI to thyroid cancer risk stratification, and particularly focusing on the different modalities of data that are involved in the diagnostic process and how we can extract information from those and then bring those together in order to, again, improve patient care. So just to start, I have no conflicts of interest in relation to this presentation. And so just to begin, I'll give a brief background on the burden of disease and what exactly thyroid nodules and thyroid cancer are. So thyroid nodules are extremely prevalent. By age 50, about half the population will have at least one that is incidentally discovered. And these are largely benign and harmless. So 90% of these, or more than 90% of these, are going to be benign. And even if you have malignancy, the 5-year survival is 98%. So the problem isn't really that people are dying of thyroid cancer, which is great. But the reason that, or part of the reason that we have this such a high survival is that the treatment is extremely aggressive, or at least extremely aggressive relative to the actual risk that it presents. So there are over 600,000 thyroid biopsies that are done every year, and overall, the malignancy risk is only about 5%. So the vast majority of these end up being benign. And about 20% of them are actually indeterminate, where they aren't able to come to any conclusion on those. And we'll get into what that means a little bit later. So the goal here is not necessarily to prevent thyroid cancer death or negative outcomes, because again, that is a very low percentage of happens very low percentage at the time. It's a relatively low risk. What we want to do is decrease the burden of these biopsies and surgeries and different procedures, because again, the vast majority of those end up being benign and are therefore probably preventable. And so we want to be able to better identify which nodules are high risk, and then be able to potentially eliminate some of these procedures without missing any additional cancers. So again, I'm a computer scientist. So I am bringing AI methods to the table on this, and basically our lab is trying to apply those methods to improve this risk stratification. So and one of the things that we want to be able to do is incorporate all of the different data that's available in order to make these decisions. So I'll go through a little bit on the diagnostic pipeline in a minute, but the data that's available includes ultrasound imaging, molecular test results, digitized biopsy slides, and clinical reports. And what we want to do again is reduce the false positives while preserving the sensitivity. So we don't want to miss any additional cancers because then that survival rate might start to drop, and we don't want to touch that. But we want to reduce these false positives so we have fewer of these procedures where it ends up being unnecessary. Um, and a main focus right now is on these indeterminate biopsies. So when a biopsy is done, but because of the sort of unspecified nature of the cells, they're unable to make a clear determination of the malignancy there. And again, I'll talk about that a little bit in a minute. So here is the clinical pipeline or a flowchart of the pipeline, and I'll step through it just to kind of, again, give an idea of how this procedure works or how a patient moves from an incidental finding to a treatment and long-term projection. And the data that's acquired along the way and how we might be able to then incorporate that into a multimodal model. So in the beginning, someone presents as suspicious for a nodule. So this usually comes from one of two, or as a result of one of two things. One is they're symptomatic, maybe they're having trouble swallowing, maybe they felt a lump in their neck, something to that extent. And then the other is an incidental finding on other imaging, like a chest CT that might include the neck. And so if someone comes with that presentation, they usually get an ultrasound exam in order to investigate. So an ultrasound exam is pretty ubiquitous. Most people are probably familiar with it, at least to some extent, maybe not in the context of thyroid, but it's used in many different areas as well, but generally involves a probe being pushed against the skin, and that will get kind of this depth image of the underlying tissue. And it's great because it's non-invasive, it's cheap, it's universally available, but it has some drawbacks because it is low resolution imaging. It has poor contrast. It can be difficult to visualize the boundaries of nodules. And it's also very dependent on the operator because the probe is held manually. So someone who's more experienced might get a better view of a nodule or of the thyroid than someone who is less experienced. Um, and then once the images are acquired, or I guess I'll also say, many images are acquired during an exam. So the probe is moved around and a combination of video, so real-time image or recordings for while the probe is being moved. And then there are still frames where the technician will hold the probe stationary in one position and then press the button, save that image. Exams at UCLA usually involve upwards of 40 still frames and then somewhere between 4 and 8 videos. So there's lots of data involved in this. When a physician looks at these images to make a diagnosis, they use the Thyroid system. I won't go into that too much here, but it's just a way of standardizing the reporting across institutions and kind of reducing things into a score. If the nodule is deemed to be at risk of being malignant, then it moves forward to a fine needle aspiration biopsy. So this is a liquid biopsy. It's minimally invasive. So it involves putting a needle into the nodule and then pulling out a liquid specimen or a liquid sample from from that tissue. And so because it's minimally invasive, it doesn't have too many complications, but with anything that isn't non-invasive, it still involves discomfort. It does involve a fairly thick neck needle going into the neck, and can have complications like infection and stuff like that. And on the right, I have a table of the breakdown of the different scoring of nodules. So um, here, the Bethesda system is used in order to create categories for the different nodules, where it goes from 1 to 6. But really, there are three different categories that with clinical significance. So there's Bethesda 2, which is benign. Bethesda 3 and 4 are indeterminate, and then 5 and 6 are malignant. So if something is 5 or 6, it's very likely to be malignant cancer. It's 90 plus percent. Um, and if something is Bethesda 2, it's very unlikely. It's 0 to 3%. But 3 and 4, this indeterminate range, takes up about 20% of all biopsies, and the malignancy rate is somewhere in the 20 to 30%. So it's not extremely high, but it is also very far from zero, right? And so um, then if in the case of an indeterminate biopsy, the physician is presented with the choice because there's no additional information um, or traditionally, there was no additional information that could be acquired from the patient. So they have to decide, do they treat or not, where the malignancy rate is around 20, 30%. So the traditional approach for this is just go straight to surgical resection. So saying 20 or 30% is too risky to not do anything. And so they just go and they perform surgery. And thyroid surgery is a significant surgery. So it has all the different surgical complications involved with taking out a piece of the body. And in this case, it's in the throat, which is a dangerous area. Um, and then also the act of removing the thyroid means that someone is going to need to be on hormone replacement for the rest of their life, unless to avoid hypothyroidism, which basically will reduce someone's metabolism, lead to weight gain, and many other nasty complications. So we don't want to do these surgeries if we don't have to. And and again, traditionally, this was kind of the only option in these indeterminate cases. In the malignant cases where it's most likely actually malignant, like 90% plus, this is kind of the only option. But in these indeterminate cases, has more recently been this advent of molecular testing, where we can get some additional information. So molecular testing applies next generation sequencing to the FNA samples. And then they do malignancy risk stratification on these indeterminate nodules and then use that to guide the decision making. And it's designed to maximize sensitivity. So the goal here is similar to what how I presented our work. They don't want to miss any cancers. They want to make sure they don't miss anything. So they're willing to accept a certain level of false positives in order to ensure that they don't have any false negatives. And as a result, they have a really high sensitivity. So they have almost no false negatives. They're able to detect just about every cancer. But their positive predictive value or their false excuse me, false positive rate is very high. So if you have a positive molecular test, it's still only a 50-50 shot that it's actually malignant. But it's much better than it was before because previously it was maybe 2/3 to 3/4 that it wasn't. Um, so even with molecular testing, many benign nodules still undergo surgery. So what we wanted to do is incorporate other information in order to improve on this specificity without losing any sensitivity. So So again, like this molecular testing is done independent of all the other steps that came before. They're just looking at the molecular profile. And so we hypothesized that we might be able to integrate some of that other information in order to improve on this result. So we're not the only group that has attempted AI on or in the domain of thyroid cancer risk stratification. Um, but there have been limitations in the prior studies. So the vast majority have been working with ultrasound imaging because that is the most prevalent type of data available and easiest to acquire and and all of that. And these prior approaches usually rely on explicit annotations and manually selected images. So as I said, there are multiple images and videos from every study. Usually these prior AI approaches will say, okay, well, a physician will go in and they will pick one image from that, and they might even draw an outline around the nodule itself. And that will be the input to the AI model. So this requires additional effort on the part of the physicians, which makes it less likely that they'll want to adopt it. It also makes the results operator dependent because different physicians might choose different images. They might draw the contours differently. And so if we can fully automate this, it would be much more robust. And then it throws away information. So if it's only looking at that one image, there might be multiple images that can capture that nodule from different angles that can give more context about how big that nodule is, how heterogeneous it is, things like that. Also, pretty much universally, these prior studies have used single modalities. So they don't use all of the information that's available, and they lose valuable context that goes around this. So what we want to do is we want to apply our methods to these different steps in the clinical pipeline, and then integrate all of the information that's available at each of these steps. So the first stage here is we want to work directly on these ultrasound images. We want to be able to identify the nodules automatically, and both which images they appear in and where they are in those images. And then we want to be able to automatically classify those images, so identify which of them are benign versus malignant. Then moving forward to the biopsy, we want to be able to extract features from these biopsies, and ultimately we want to make decisions based on that as well. We haven't gotten to that point, but I'll talk about future directions for that. Um, the the next step, we also want to look at the reports themselves. And this is valuable from a couple of contexts. One is that it can pull out information coming from the clinicians that is based on their knowledge and expertise, and possibly other information about like clinical history and family history and things like that that end up in the reports that aren't explicitly in the images themselves. And then we also want to be able to link findings across different reports and studies. Because if we have a biopsy result, we might not know where in the thyroid that was coming from and which nodule that would apply to within the ultrasound imaging. And so the reports are a way that we can do that linking as long as we're able to extract that information. And then finally, we want to use multimodal models that bring everything together, particularly for the indeterminate nodules. We focus on those because that is the kind of last step in this pipeline where it has the most different modalities of information that are available. So we have the most to gain from a multimodal approach. So just going to step through those different projects that we have ongoing, and I'm going to kind of go pretty quickly through the first few because the focus here is on that multimodal approach at the end. So first project that we had in this pipeline is the the task of segmenting and detecting nodules from images. So this has been done many times in the past, but the issue that we found when we did our review of previous literature is that just about every prior study only worked with the images that have nodules in them. So they would start with an image and that a physician has verified has not a nodule in it, and then they would train a model on those images and then detect where in the image that nodule was. The problem is that the vast majority of images don't have nodules in them. This is even for patients with thyroid cancer, because again, they have upwards of 40 images in their study. And so if you train a model only on images that have nodules, the model will learn that every image will have a nodule. And that is exactly what we found when we put our images into these existing nodules. They would find a nodule no matter what was there. And so we aim to build a model that would be able to distinguish whether or not there was actually a nodule present, while simultaneously also drawing the contour around those nodules. And so on the right, I'm not going to go through all of the different examples here, but the idea here is that we were able to add what's called an anomaly detection component to the model, and that was able to filter out some of those false positives. And on the right here, we have a bunch of box plots. And what we generally showed was that when we add this anomaly detection in there, it has drastically decreases the false positives, but it also has some false negatives. It doesn't detect nodules anymore. And we were alarmed by that because, again, the goal here is we don't want to miss any cancers. But then what we did was we broke it down into these quartiles. So we said, okay, we'll look at the largest nodules and the smallest nodules and see is the performance any different when we look at these different quartiles independently. And what we found was basically in the third and fourth quartiles, the biggest nodules, the ones that are most likely to be clinically significant. There was no significant difference between the nodules that were found using our anomaly detection versus not. What we Where we started missing things was on the very small nodules. And it makes sense because if you train a model to say, okay, well, there's always a nodule here, well, it still might do fairly well in detecting the smallest nodules because it knows something has to be there, so it will take its best guess. Um, Whereas our model is then making a determination, well, is that actually a nodule or is that a calcification or something like that? And so there was a significant difference on those smallest ones. Um, but what we also did is we looked between two different physicians and wanted to see, okay, well, how often do they agree? And that's this table in the bottom right corner. And we find half the time the physicians didn't actually agree on the smallest quartile. So the reality might be that a lot of these might not actually have been nodules. And likely, although we didn't test this directly, a lot of those might not have been clinically significant anyway. The next step in the ultrasound approach was doing classification, running a little low on the time, so I'm going to start speeding up a little bit. But again, lots of studies have tried this, but they pretty much require a single frame, possibly a manual segmentation. And so what we wanted to do is incorporate this idea of multiple instance learning, where it can take in all of the images with the understanding that only some of those images will actually include important information. So the model simultaneously tries to learn which images and regions within images are important, while also learning what the important information is. And so this better aligns with real-world diagnostic process practice because it can incorporate all of the images at once and integrate information across those images. Um, and it also doesn't require that additional manual step. So there's one prior approach that did this. They worked at the image level where they had an image level deep learning model, ran individual classifications on every image, and then aggregated across those images using multiple instance learning. Um, and they showed some reasonable accuracy. Um, we took that an additional step where we didn't just do it at the image level, but we also did it within the image. So we're not just learning which images are important, but also which regions within those images. And that allowed us to make a pretty substantial improvement. Um, the downside of that approach is that even though it is considering information from all images in a study, it doesn't take into account the relationship between those images and the areas of images, because the ultrasound probe is uh, is potentially capturing different angles of the same anatomy, and so those images aren't all independent. Um, and so the challenge here is we wanted to utilize knowledge about where that probe was in order to integrate that information better. And so the way we did this is with a graphical model where we had an atlas of a thyroid and created a spatial graph within that and mapped all of the images onto that graph. And through graph convolutions, we were able to utilize that anatomical information. So this is kind of a visualization of how that was done. And then in the end, we showed yet more improvement. It's statistically significant, although the magnitude of the change or the effect size over our previous approach isn't that big, um, but it's still an improvement. And one of the nice things that comes out of this is then we can go back to that graph and the atlas and use that to show where the model focused in order to make its determination. So in these examples on the left here, um, we have two different thyroids. The one on the left had a single malignant nodule. The one on the right had one malignant nodule and one benign one. And so you can see that it kind of heats up um, it shows a heat map that indicates like where the nodule was, or it aligns with where the nodule was. But it's really just showing where the model saw information that it thought was useful. So, still ongoing work there. We're doing lots of things with ultrasound, but I do want to kind of step through all of the different parts of this pipeline. So next is digital cytology. So the goal here, once we have the liquid biopsy, then it's put on a slide, and the pathologist or cytologist will look at that slide under a microscope and characterize the cells within it in order to make a determination of malignancy. And again, there are kind of three categories here: benign, indeterminate, and malignant. So we started out just trying to do this sort of naively, going straight to our task of thyroid cancer, and we kind of ran into um, some roadblocks here. Primarily, UCLA doesn't currently by default digitize all of their slides, so we had to go and pull the slides from a warehouse and then scan them ourselves in order to use them. And these models are very data hungry. And so that wasn't really a great approach, at least to get started. So we took a step back and we decided, okay, well, rather than this direct approach, we would start with building a foundation model. So we would try to get cytology information from as many different organ systems and diseases as possible, and try to train a model that would be able to extract the features from those. Um, that we would then be able to apply to our thyroid cytology images in order to then turn that into a downstream classification task. And so here we used iBot. That's a pretty standard, although it's a little out of date now. This was a couple of years ago, and this is a fast-moving field. But we used iBot for the first pass on this, and we created CytoFM. And so this is trained on, again, multiple different cytology, disease, and organs. And and what we showed is that our model was um, better than a lot of the kind of standard models that existed previously. So it's no one had previously tried training something directly for cytology. But there are lots of these models for like general imaging. And so these are our three downstreams for this first pass, where we show that on two of the three, we outperform the baselines. On the third one, we underperformed a bit. Part of that is because that was on breast cytology, and we had very little breast cytology in our training. And so we believe that that probably would increase if we had a more representative training data for that. And then down below, won't get into it too much, but we can visualize the different features and um, how they cluster both within the images to show like what parts of the images the model is seeing as important, and then also in the embedding space, whether showing that the classes kind of clustered together, demonstrating that those embeddings are capturing that information. Um, and then the next project is this idea of entity and relation extraction. So I talked about this a little bit previously, but the reports that accompany images are rich sources of information that include a lot of context that isn't directly in the images themselves. It also brings in the expertise of the radiologists who made the or pathologists who made the assessments. And it allows us to link between the different imaging studies that can show um, how the information in these different reports might relate to the same anatomy, and also looking at multiple reports over time, kind of getting a longitudinal representation of a nodule where we could say, okay, there was a nodule last year, there's a nodule this year. Is it the same nodule that is maybe grown, or is it a new nodule? Um, and so the way we did this, we applied Quen, which is a standard LLM. Um, we have this hosted locally, so we don't have to worry about PHI. And we applied it on radiology and pathology reports. And so again, the idea was that it would be able to identify all the features related to individual nodules and then relate those across reports. So there's an example on the right here where there's the radiology report at the top, and it's able to identify the two different nodules that it's talking about within that report. Then there's the report for the subsequent biopsy below that, and it's able to figure out which of the two nodules from the radiology report it was ended up getting biopsied. And one of the nice things about Quen is that it can also give you this output about its reasoning for it. So here it talks about how it identified that the biopsy report said increasing size. And in the radiology report, one of the nodules had a previous size that was smaller, and the other one had a previous size that was the same. So it determined, okay, well, then it used that reasoning to identify which of those nodules applied to the biopsy report, even though the report itself didn't have anything directly linking it to that. And this allows us then to, again, incorporate that information from the biopsy and the radiology in a more sophisticated manner rather than just trying to like append feature vectors or something like that. So finally, we want to bring all of this together for multimodal models. And so we have some preliminary work on this and a paper that I'll get into in a second. A lot of this remains as future work, though. So we want to bring everything back together to have like one model that can potentially use the imaging, the molecular tests, the digitized biopsies, and the clinical reports together. Um, and um, and so on the right, we have kind of a flow chart of how that could be. And this is pulled from a grant that I have in submission right now. It's we're moving really fast on this. We're not actually going to follow this exact process anymore because we've already made changes to it. You might notice this doesn't say anything about an LLM, for instance. That's something that was newer since we submitted that grant. But yeah, this is the general idea, trying to bring all of that together so that we can reduce false positives, but preserve that sensitivity. So for this specific data set or specific study, we have this retrospective review of patients that had indeterminate biopsies at UCLA over this 6-year period. And this is the patient cohort we ended up with. And you can see it's these are all patients that got those biopsies and those and had indeterminate results, and traditionally would have all gone to surgery. And I didn't note before, like molecular testing costs money, obviously. Um, Lots of places don't have access to that, and so they still do surgery on everyone with an indeterminate biopsy. So you can see here it's about 3/4 end up being benign, and so that's lots of thyroids that come out that didn't need to in most cases. Um, yeah, there are two different molecular testing platforms that were used, ThyroSeq and Afirma. There are a couple of others that exist, but these are the two that are used at UCLA. And we had binary labels, just benign versus malignant. One thing that I will note here is there's this kind of third class NIFTP that we treated as malignant based on previous work or previous literature. That's a little controversial within the field because the prognosis is very different from a more direct malignant nodule. Um, so we recognize that like grouping that in is a limitation. We have done sub-analyses to see whether the results still hold on if those are treated separately, and the results still do hold. So here's generally how our model works. I'll step through it in a little bit. One thing to note so this is kind of the attention MIL um, or multiple instance learning that I presented for the ultrasound, where molecular testing is kind of appended at the end. So we didn't use the graph model for this because our data set was a little bit small, much smaller than our data set for that study. And so we wanted to start with something that was as simple as possible for our first approach here. We used a pre-trained ResNet 101 for getting features from the input ultrasound. We did that both at the full image size level and then at different sizes of patches, so we could get different levels of context. Um, and also include higher resolution, so we didn't have to downsample the whole thing. And then we applied a attention-based multiple instance learning. So again, talked about this a little bit earlier, but the idea is that we make an assumption that there's this patient level label where someone has thyroid cancer or they don't. And they have lots of images, some of which will include evidence of that cancer, some of it that won't. And then we have this attention module that will learn which of those images are important. And so we simultaneously learn which images are important as well as what information from those images. And then we bring in the molecular testing information from the molecular testing reports and then feed that into an MLP for the final classification. And what we show here is on the right is the ROC curve. It's a little hard to see on this. I apologize. But you can see the blue here, that is the clinical baseline. So that's just if molecular testing and Bethesda score are used in order to make a determination. Notably, the Bethesda score is only 3 or 4 here because we're only considering um, the indeterminate results. And so you see kind of what we were showing, or what I said at the onset here. Sensitivity here is very high, 0.95, and specificity is 0.66. So a little bit higher than I was saying before, where it was closer to the 0.5. Um, but if we have this ensemble model where we bring in all of the imaging from the ultrasound, we drastically improve the AUC, but more importantly, because we want this to be something that clinicians use, AUC isn't that useful for a clinician because it doesn't tell them what to do. Um, but if we match the sensitivity of the baseline, so we choose a decision threshold such that we have the exact same sensitivity, that 0.95, um, our specificity significantly improves. So now it's up to zero point 0.7. So this means that we have successfully identified some cases that do not need to go to surgery that previously would have or did, because this is retrospective. Um, and we haven't missed any of the cancers that were previously found. So no one's risk or prognosis got worse, and we were able to identify a significant portion of these procedures that didn't need to happen. And then we can go back and use those attention scores to identify different regions. Um, I'm pretty low on time, so I won't get into this too much. Um, this isn't quite as helpful as kind of that 3D model that we're able to get out of the graph. But we can still highlight different areas that the model thought were important when making its determination. So in this case, it found this hyperechoic rim that's around this nodule. Here it found an isoechoic and hypoechoic nodule, and kind of looked at the interface between that nodule and the deep surrounding tissue. So these are things we pointed out to or we showed these to our clinical collaborators, and they kind of said, yeah, these are the regions that they would look at um, when making a determination on these. So it's not a systematic analysis by any means, but it at least shows that our model seems to be looking at the right areas. So that covers all the details. So just want to summarize. So made some contributions here where we're looking to bring in all those modalities and use multiple instance learning to combine them in order to allow the model to identify what features are important and how they kind of combine and integrate. What we definitely want to do in terms of translational prospects for this is maintain that sensitivity. So we don't want to maximize our model on accuracy or some other statistic, because we want to keep in mind how this relates to patient outcomes. And so we want to ensure that we're not making some determination on um, like false positives versus false negatives, and like potentially missing lots of cancer in service of reducing those false positives. We want to make sure that we preserve that high survival rate. Um, but we want to eliminate eliminate like unnecessary surgeries, and this means reducing those false positives. And so this is designed not to replace the different steps in the diagnostic process, but actually to augment them so that we can incorporate all of that information together. Um, and just want to point out, there are over 100,000 indeterminate fine needle aspiration biopsies every year that are indeterminate. Many of these go to surgery directly, even without molecular testing. And even of those that get molecular testing, still half of them that the testing says are at risk end up being benign anyway. So there's lots of, even with a relatively small change in that specificity, we could potentially impact a lot of patients' lives. Um, Multiple limitations. Right now, it's single center. We are trying to expand this. We have some collaborators identified. Um, we also, again, use these NIFTP nodules and treated them as malignant. So we do want to kind of further stratify things so that we don't make that assumption. I pointed out in the beginning, we have this kind of overall goal of bringing all of the modalities together. So far, that has not been fully realized, but we've done lots of work towards extracting the information from the different modalities. And so once we have all of that secured, then we can integrate them into our multimodal model. Yeah, and so I covered most of that stuff. So want to thank all of the collaborators. Lots of people are involved in this, both within the Bear Lab, also the medical informatics program here, radiology, pathology, and our external collaborators. So that is it. So thanks a lot.
Thank you, Dr. Speier.
Uh, Thank you, Bill. This is fantastic. We have a format. We take questions from the audience, and some of them you can see it, others you cannot see it, but they would submit the questions to us. If it's okay with you, Bill, I'm going to go to the first question. I'll read it out loud
Yeah.
for you. Okay. So the first question is, when you created your attention MIL encoder, what did the attention maps look like? Were they only a few frames, where the attention was high, or was the attention uniformly sort of spread out?
That's a good question. And I think to an extent, I don't have a universal answer for that because I don't think have done an extensive like systematic approach for that. Generally, it is pretty sparse, which is what we would want because again, there are 40 plus images in a study. Most of those don't involve any nodule. Sometimes there are multiple nodules and but yeah, and so I did show a couple of examples there at the end, and you can see here that there was only one patch in that image that's lighting up. Um, and obviously, I'm only showing two patches that actually have nodules in them, but a lot of the images without nodules, they wouldn't have anything highlighted. And generally, also we use different levels, so different patch sizes, full image versus the smaller ones. Um, Generally, full images didn't really get used that much because the information is not specific enough. So it's largely the patches and usually only a few.
Very interesting. The next question, Dr. Speier, is from one of your students, Stephen Sway. And here's a question Stephen asked. For attention-based machine learning approach, what might be possible methods that you would recommend that can inject prior knowledge? Example, the most useful frames are likely to be in the middle.
So a prior on that. Um, so I think there are a couple ways of doing that. One is if you have sufficient data, you might hope that the model is able to figure that out on its own. Um, because generally, a lot of times we like to try and bias the model as little as possible. So that we allow the model to identify what things are important, because what we expect to be important may or may not actually line up with what is useful for a model. That being said, we also don't. We often have limited data, so we do want to kind of push it in a certain direction. So an explicit prior isn't something that we usually try in this. One thing is it might be sampling. So for a lot of things, particularly with like pathology, there's so many patches that we can't really put all of them into the model, or we might not want to because there are just so many. And so we might bias the sampling of the patches based on our expectations. That's actually for the CytoFM. That's what we do on that because again, cytology images, they're huge. And so if we just had it look at everywhere uniformly, it would be really inefficient because we'd be putting a lot of empty patches into our model. And so we have this prior um, step where we run the patches through and identify whether there's information there at all. And then that will allow the model to kind of focus on the right areas.
Thank you. Our next audience has two questions, and this is from Abdul. The first question is for feature and relation information extraction. How did you mitigate the hallucination effect by Quinn? And what was the evaluation on these extracted information to be true before we could use them? That's the first question.
Oh, that was the first question. I thought that was already both. Okay.
The first
No,
question had two parts. Had two
yep.
parts.
No,
Yeah.
great. Yeah, so hallucination is definitely a concern, and it's something that we were definitely worried about when we were doing this. So I guess the answer is kind of goes hand in hand. The evaluation on this is involved. We had experts go in, so we had a couple of physicians go through these reports and identify um, the TIRADS features and the Bethesda features from those images, or sorry, not from those reports. And so we had the gold standard for those, and they also identified which regions, sorry, which segments from each of the reports corresponded to which nodule. So this was with multiple nodules kind of in a list. And so we were able to because we had these manual labels, we were able to directly compare the outputs to those. And in basically every case, it did very well. I don't have the numerical results here, but they're in the paper. Um, and there were cases, particularly early on, because this went through a lot of iterative refinement. But early on, we would see things where it would make up a TIRADS category if it was missing from the report or something like that. And so that was part of the evaluation where we said, okay, um, uh, basically for every entity it extracted, um, is it uh, did it successfully find something? Did it miss something that was actually there? Um, did it successfully identify that it's not there, or did it make something up that isn't there, or did it make something up that doesn't match? And and generally speaking, for this task, it was um, after working with it a bit, it didn't do I won't say it won't do any did I won't say that it didn't do any hallucination, but it didn't do much. Um, because again, it did very well on this extraction task.
Wonderful. So the second question from Abdul is which part of the multimodal workflow you have shown has the highest contribution to the pipeline? Is it the imaging, the ultrasound part, or is it the clinical data part, or are these two contributed equally?
So right
That's the
now, oh,
question.
sorry, were you finished?
Yes.
Okay. Um, yeah, so the multimodal, at least in terms of like modeling, right now is just ultrasound plus molecular test and then some other like demographic stuff and things that are pulled out in a previous version. So not the LLM, but like a more simplistic regex type of information extraction from the reports. Um, and so the molecular test does have stronger information than the ultrasound. So ultrasound by itself does not do nearly as well as molecular tests. But what we do show is there is a delta when you incorporate that ultrasound into it. We believe that the pathology or the cytology will have a bigger effect on this because that will actually have um, like cellular information that it's more specific than the ultrasound itself. And so that is an important next step. But again, like when we were doing this multimodal, that's when we were still trying to go directly to the thyroid cytology images, and we just weren't getting enough data in order to train those models. So we're not there yet where we haven't um, been able to incorporate that information, but I think that has the most promise.
Or value to the pipeline here. Uh,
Mhm.
well, thank you, Bill, and thanks to all of our audience asking these very interesting questions. We really learned a lot, and we appreciate this very insightful and very stimulating lecture. Back to you, Jack.
Yeah, thank you very much, Dr. Spear. We're really glad you were able to present for us, and I'm sure the British 2AI community will definitely benefit from your awesome insights. Everybody just stay tuned. Also, we will be having another lecture by Dr. Kosuke Inoue on March 26th on identifying heterogeneous treatment effects using machine learning for future precision medicine and public health. So stay tuned and lucky to have you all. Thank you for tuning in.